Good morning.
Good morning.
My name is Dr. Marcy Schnorr, and I coordinate parish nursing for Lutheran Church Missouri Synod. And it's almost 25 years we've been doing this. And we're looking forward to maybe something special where we can provide a course for people in the United States who are having some difficult time finding one, but also our friends abroad. So I'm glad you're able to join us today. So what is parish nursing? Well, you know, a lot of people, even though we're 25 years old, a lot of people just heard of it and have no idea what it is. Others have been doing it for a long time. So let me give you just a quick glimpse of practicing parish nurses. And of course, I'm going to begin with the Lutheran Church Missouri Synod. And this is just a picture of one of our parish nurses in Missouri, actually, doing something at a convention for pastors and other church workers. Parish nurses may also work within their congregation, and this is at a health fair conference where basically the focus is on foot care, but it also includes the spiritual care as we talk about our walk with the Lord. Another parish nurse in the state of California who is checking her clergy's blood pressure after a sermon on Sunday morning. And clergy health is an important part that we include when we're looking at the care for the whole congregation. This is a parish nurse also in California who's doing home visits. So many parish nurses do home visits, but not in the same way that a home health nurse would do. We're not doing invasive care. We're not doing anything that would be repeating or conflicting with someone else. Certainly monitoring health needs, blood pressures, explanation about medication, but first and foremost, also including a connection with the congregation, including a time of prayer, including some scripture, and also keeping the pastor and the parish nurse as a team so that the person doesn't get lost on the communion list. Parish nurses never stop learning. We have an annual conference every year, and this looks like the annual conference at Concordia University, Wisconsin, where parish nurses come from all over the United States, primarily from within the LCMS, but also others, for 2 days of conferencing and networking. The Lutheran Church in Australia also has parish nurses, doing very similar things, but in a different structure. They also have regular conferencing and continuing education. We have our office with typical office nurse things and home visits. In this case, not to the elderly, but to a young mother who has questions about what to do with her child. But they still take blood pressures. This is a blood pressure screening on Sunday morning after a worship service. The Lutheran Church in Canada is involved, but not as active as we are, but they do have a networking. The Lutheran Church in Jordan and the Holy Land has one parish nurse, and this is a parish nurse making a home visit. And again, one of the important things is to pray with the people and to network and encourage and support. This is a group of volunteers that works with her. Another home visit. We move on to Finland. Finland boasts of having parish nurses, although they use the term diaconal nurses, because in Finland, their parish nurses are really nurses and deaconesses together, and so they use a different term, but it really is the same thing. It's putting the body, mind, and soul together. And I'm glad we don't have to do this. This is their aquatic therapy, and since I don't swim, I would have a real hard time doing that particular part, but they do a good job with it. And this is their group outside their cathedral and sort of graduation day. This is a group of parish nurses in Finland, but you see Finns, Palestinian, Australians, and Americans all together. And this is part of a group known as Lutheran Parish Nurses International, where we have people who are parish nurses in any of the Lutheran churches around the world who meet together for networking and support. This is a group that met in India last year. And I was blessed to have the opportunity to go to India, and we had 17 nurses in Ambur, India, who took the course. And doing exactly the same things we did here. They're just initiating it, have begun some things with women, children, and the elderly. And this is the graduation at Ambur, India. The one that is not dressed in a sari is me. And the Lutheran Church in Australia recently taught a course in Papua New Guinea. So we have some beginnings in New Guinea. But the key thing is, in all of them, you're sharing Christ-centered, compassionate care to people in His name. So, like another nurse, our skills and our knowledge of nursing are the same. A blood pressure taken by a parish nurse is no different than a blood pressure taken by someone else. But the difference is, the parish nurse is coming as a representative of the church, is also praying with the person, is also sharing the good news of the gospel, and is also a connecting link back to their congregation. Okay, having given you a little glimpse of what parish nursing looks like now, I'd like to go back for just a little bit of a historical overview and see, where did we begin? It actually is not new. It began with the ancient Greeks and the Romans. Now, they didn't use the word parish nursing, but they used the concept. The concept was there caring for the whole person, body, mind, and soul. Now, a little bit later, the Greeks divided the person up, and they had the body in one spot and the soul in the other. And then it became more complicated. The Christian Gospels. If we look at the Gospels, we see that many, many stories about Jesus reaching out to the healing. Okay, can we think of any examples of Jesus' healing ministry?
Leprosy.
Leprosy.
Making the blind see.
The blind to see.
The deaf to hear.
The deaf to hear. And the examples go on and on and on. He's called the great physician. A body, mind, and soul. We have 4 Gospels. One is written by someone who was also a physician, and his name is Luke. Okay. And Luke, the evangelist and the physician, is one reason why every year most churches that have a parish nurse recognize St. Luke Day. It's a way to reaffirm and rededicate. It's also a way for their congregation to realize this is a part of our ministry, and it's not just the nurse that happens to be in the church. It is a specialized role of nursing. The first parish nurse is Phoebe. Now, interesting about that, deaconesses also claim her as the first deaconess. And in history, traditional history books will talk about Phoebe being what was known as a district nurse. And a district nurse is by definition and description the same thing that a parish nurse does now. It's the district within the church. England uses that same model and calls their parish nurses districts. Paavola, Theodore Fleidner, these were also people who were involved in the caring, compassionate healing. Norway began in 1865. They have a long name, which I cannot pronounce. It's in your literature. If you want to read it, it starts with an M, and there's probably 20-some letters in the word. And then in the United States, it began in the 1960s with Dr. Granger Westberg. And it began in 1988 with bringing a coordinator to Lutheran Church Missouri Synod, and in 1989 is when we actually began our parish nurse ministry. So the history is a long one. It is not a new fad. And so we began in 1989. Lutheran Parish Nurses International began in 2008, and our most recent country that was involved was India in 2012, and at the same time, the Lutheran Church in Australia reached out to Papua New Guinea. So 2012 actually had 2 new groups coming in, one as an outreach from LCMS, The other one is an outreach from the Lutheran Church in Australia. So that's a very brief history, and now we bring it up to where are we presently. Presently, we are involved in LCMS. We have 35 districts. We attempt to have a district representative in each of those districts, and that district representative will work with the parish nurses in their area. In total, we have over 1,000 that we know of. There are probably more, and we're continuing to expand. So the history has gone a long ways. It started with about 6. We're now well over 1,000. It started with nobody in a district. We now have 35 districts. We have a council. We've gone international. Okay, we've kind of identified what parish nursing is, but now we'll look at how does it work. And there are lots of different models, but there are 4 that are the most common. And let me just briefly introduce those to you, and later on we'll talk about ways that we may involve them in your own particular congregation. The 4 main models for parish nursing is institutional paid, institutional unpaid, congregational paid, and congregational unpaid. Now that sounds pretty simple, except it's not really as simple as that. So when we look, what's the difference between institutional and congregational? The simple thing is an institutional model means that the parish nurse is an employee, usually of a hospital, and the hospital enters into a contract with the congregation. And depending on the terms of the contract, it may be paid or not paid. And if it's paid, a certain percentage may come from the institution, the hospital, and a certain percentage comes from the congregation. And that percentage will change over the years until eventually the congregation pays it all and the hospital maybe covers the insurance or something on that. Having said that, not all institutional models are paid. Some are nearly simply a community outreach, and there's an agreement on use of resources, an agreement on providing speakers for a speakers bureau, an agreement on substance, but not necessarily money. Congregational, paid or unpaid, it's the same principle. Only in this case, the parish nurse is on staff at the congregation and owes no allegiance to the institution. And in the congregation, the parish nurse will always be considered staff, but it may or may not be paid staff. Some parish nurses are fully salaried, benefits, full-time, and everything that would go with any other regular staff position. Others are very part-time, perhaps with no reimbursement, or perhaps with an honorarium, some travel money, some expense money. The differences are as unique as the parish nurse and the congregation. So we could spend all day looking at, what are the differences. So the money. But since most parish nurses aren't in it for the money, that's really not the primary point. The primary point is just looking to see where does compensation come from, if there is compensation. And in some cases, the compensation is not financial. It may be in other services provided. So the selection of the parish nurse, if it's an institutional model, the determination as to who's going to be the parish nurse is shared between the institution and the congregation. So the institution, since they are the funding source, certainly has a right to determine who they're hiring. But because parish nursing is part of the team ministry in the church also has a right to know who is it that's coming into our church to provide some ministry. So they have to agree. In the congregational model, it's simply the congregation determines that. And it may be the pastor, it may be the board for human care, it may be the elders, it may be a full congregational vote in a decision at a business meeting. How that happens in each congregation will depend upon the structure and the constitution of the congregation. As far as referral sources, Later on in the course, we'll talk about the main roles of parish nursing, but certainly one of them is to make some referrals. If you are an institutional model, they would prefer that your referrals are made to them. Okay. So it doesn't mean that it has to be made to them, because if the person needs a service that they cannot adequately provide, of course you'll refer someone else. But if that institution could provide the service, then that's the place you would refer to. In the congregational model, you owe no allegiance to any institution, and you simply make your referral based on where you think is going to be the most convenient and the best service provider for that particular individual. The issue of liability. Liability for any nurse is true. So we can't have a class without thinking of liability in some way, because you're still a nurse. Even if you are not paid, you're still a nurse. We still have to follow the Nurse Practice Act. We still have to do all of those issues. But what I do need to say is the liability risk is very minimal for a parish nurse, because we're not doing invasive procedures. And liability generally comes when the person is not comfortable with you and the services you provide. Most people love their parish nurse because you have a relationship, you've known each other, you're part of the same church. That risk factor is not there. And yet, I can't tell you it's not there at all. So you need to look at it. In the institutional paid model, the institution picks up your liability insurance. In all of the others, it's an individual negotiation. They may or they may not. Regardless of whether they do or they don't, I personally advise the parish nurse to have her own liability insurance. Because even if you work for an institution, they will cover you up to and including what liability you have on behalf of them. But for all the things you do when you're not on duty, is still your own problem. And so for the price of nursing liability, it's a real cheap investment to just have it yourself, and you don't have to be concerned about it. The position description, institutional model, they are the ones that define the position description. You agree to it or you don't agree to it, but it's their position description. In the congregational model, the position description is written by the congregation, but with input from the nurse. And there is a sample job description in all the materials that you've been given on what we sometimes provide in LCMS for people. Where do I start? What might be something to consider? That doesn't mean you have to use that job description. It just means that job description is a good sample for you. Okay, and that is in your materials. So let's talk a little bit. Each of them have advantages and each of them have disadvantages. If we were looking at the institutional model, what would you see as some advantages?
The backing from the institution, the support, the resources.
Okay, you already know where you can go to find A, B, and C. You don't have to go looking for it. The institution is going to have it. Anything else?
It's already established for you.
Yeah, some things are already established. Exactly. What might be some disadvantages?
Following the rules.
Following the rules. Because a healthcare institution has a lot of rules that a church is not going to be bound by. And so we need to fit into that system.
And perhaps the client themselves may not feel a link towards that particular institution.
Okay, absolutely.
They might choose something else, and then that kind of, where does that leave the nurse?
Yeah, and certainly I think there's advantages and disadvantages to both. And so the purpose of our discussion isn't to support one and condemn the other. It's to say, take a look. Because depending on where you live, depending on what the resource is, you may have a different answer as to which one's going to best suit your needs. Okay, if we look then at the congregational model, what would be the advantages?
You probably have more input personally
Right.
with your congregation than
Okay.
you would coming from an institution.
Yeah, you have a little bit more autonomy because you are the parish nurse. You're not part of a larger system and have to fit into it, okay? I think one thing is, for the most part, pastors are a little bit more comfortable because they know that their parish nurse is in their own congregation. They know that person. And they feel comfortable, particularly that you've been educated through a course that includes our church's perspective, that includes what our church would like us to do. In an institutional model, sometimes they have their own class, which is really generic, and it may or may not mesh with the policies and the principles you have in the church. Again, some do, some don't. So it's look and see, because some are going to be really great. If you're coming from a religious institution that shares some similar values, it's probably not a problem. But if you're coming from one that does not have a religious background and does not share your values, it could be a problem. Disadvantages to the congregational model.
Well, I guess you're on your own.
Yes, exactly. So being on your own can be positive or negative, can't it? If you're on your own, you get to decide what you think works best. That's good. Being on your own, you get to decide what works best. That can also be bad, because maybe you're not sure. In the institutional model, you have a built-in network that you can bounce ideas off of, or there is a policy and procedure book that somebody already developed that you can look up and see what they told you. The only way we get around that is in the LCMS, as well as some other places. That's where our district networkings come together. You may be the only nurse in your church, but you have others in your district. And the district networks would meet together periodically, or you're only a phone call away. And you can ask opinions, we can share information. There are plenty of places that you can talk to, but not this moment. You know, in the institution, there's somebody right there at this moment. So, and also the congregation may have, as most congregations do, there's budget problems. And so it may be more difficult to have adequate financial compensation for the person who's looking at this as their sole means of support. For those who are looking at it as a part-time either active service and discipleship, or looking at it as a side to their regular employment, that's not a problem. But for the one who says, I want to quit my traditional job and I want this to be my job, it's probably not going to pay real well. No. So you need to look and see, is that important? The other side, if you're an unpaid parish nurse and they're having budget problems, your position probably is not going to be cut because you're not costing them much. So it can be more than one way to look at it, can't there? But the important thing is, whichever model is selected, being Christ-centered is essential. Okay, I think we're about ready to move on, and we'll be looking at parish nursing assessments. And we'll do this in just a little bit more detail than some of our others, because I think assessments is so second nature to nursing that we can move it from the clinical site into the congregation without any difficulty. So if we look at the nursing process, it always starts with assessment, right? If we don't assess, how do we know what we're planning? How do we know what we're going to implement? So assessments. But parish nursing assessments have some similarities and some differences from assessing just a patient. First, we assess the congregation as a whole, okay, not the individual. We're looking at the age. The age might include the age of the congregation, meaning is this a new church that just has been around for 2 or 3 years, or have they got a history of 100 years of existence? Why do you think that might make a difference? If it's a new congregation or an old established congregation?
Well, if it's old and established, they'll probably already have relational programs, even
Okay.
if they're not on paper.
Okay.
Yeah.
So there'll be some sort of relationship built together, which may or may not be healthy, but nonetheless, they're They're built together, and you certainly need to intervene in a real appropriate way so that you're not knocking out what's already there. We're adding to it, we're not destroying what you already have. What about the new one?
I think they're probably more open accepting to new ideas because they're just becoming
They're just getting
established.
started. Okay, so it's not a good or bad, it's just a difference. If I'm looking at a congregation with long history, their long history is really important to them, and we can't violate that. If they're new, they're looking for something new for an identity, and there can be positives or negatives. But I'm also looking at the age of the people there. Because some congregations may have largely young families, lots of kids, not too many grandmas and grandpas. Others have lots of grandmas and grandpas and not too many young families. And one thing that I can certainly identify is early in our parish nursing within the synod, I was mentoring a lady from a congregation, and the course asked for them to visit a shut-in. The congregation I serve, I have at least 30 shut-ins at any given time. Not using Medicare's definition of shut-in, but using a more traditional definition of shut-in. That lady had no shut-ins, none whatsoever. But they had 12 births every month. I have 12 births a year. Okay, so the age of the people in the church are going to make a difference. So if I'm in a church that has only young people, I probably don't need to spend a whole lot of time planning for a senior activity. I don't have any. But if I have one that has only older people, I probably don't need to spend a lot of time on new baby situations because I don't have any of them either. I need to be aware of both because hopefully as the congregation ages, we will have people from other generations coming in. But where are we now? We need to start with what's going to be most acceptable to the people that we have now. We're going to look at genders, male and female. Which one is probably going to be more interested and receptive in what you have to offer? The females, exactly. Women are health conscious, not only for their own health, but the health of their children. And they are oftentimes the caregiver for aging parents. They're the ones that are trying to convince their husbands to go get their physicals. They're really the health person. With few exceptions, the men tend to think they're invincible sometimes and not necessarily take good care of their health and not necessarily be terribly interested until they have a need. You know, when they have a need, then they want to talk about what do I do about this. But when we're looking at prevention, primary, secondary, and tertiary, the man is going to be more interested in the secondary and the tertiary. The woman is going to be interested in the primary as well. Ethnic backgrounds. We are a melting pot or a salad bowl, depending on which definition you like, but we have different ethnicity within our congregations. Some congregations are going to be primarily Anglo, but not exclusively, and even if they are, there's deviations within that. And others are going to be a changing ethnicity as the communities change and the demographics change. So we need to know what is the background. Again, the congregation that I'm from originally was largely German, but we have a lot of Scandinavians now and a lot of other things as well. It's not typically German anymore, although there's some evidences of German there. Family units. Do we have the family that also has mom and dad, grandma and grandpa, aunt and uncle, and everybody in the family is related to somebody in one way or another? Then if we have somebody with a problem, we're not dealing just with the identified patient. We're dealing with the parents, the extended family, and everybody else. And the more serious the condition, the more diverse their opinions and involvement are going to be, and needing to keep that all together. Conversely, if you're in a congregation that's largely mobile families, you probably have a family unit with no ties because it's a family that is mobile and they aren't related to anybody here. So we need to sometimes make those family units out of other people in the church that serve as respite or foster grandparents or whatever. Length of membership. Similar to when I talked about the age of the church. The length of the membership. The person who has been a member for 50 years may have the, why do we need that? We've never had it before. We've always done it this way. New ideas isn't always welcome. The newer membership is because they're interested in, oh, I never heard of that, but that sounds really interesting. So looking at the age of your membership, the length of your membership. Participation in worship and sacraments. We certainly are there primarily for the support of the spirit, care of the soul, but we're also there for the whole person. And the person who's very actively involved in the everyday worship and sacraments is probably also at least approachable by the parish nurse and everyone else. But what I've sometimes found is the person who is less active, when the parish nurse goes to call on them for their physical needs, even though the parish nurse doesn't have to say anything, the person will say, you know, I haven't been in church for a long time. They know they haven't been there. And we will say, that's not why I'm here. I'm here because I care about you and I want to share God's love with you and help you in any way that I can. And I'm not coming with any strings attached. But because I am coming from the church and I do include prayer and I do include spiritual care, many of those people return. Likewise, when I go do a new baby visit, particularly if it's a family from a new admission or a relatively inactive who maybe hasn't had all their children baptized. When I go to do a new baby visit, not only will I provide them some basic health care things, but I will also take a little book on what is baptism, and I have a form that I help them fill out on when do I think I'd like to plan this. In many cases, there's a couple of other kids there that haven't been either. And in some cases, also one of the parents that hasn't been either. And so my purpose was spiritual. But I didn't go up to the door and say, I've come to find out when you're going to have your baptism. You know, I came up to make a visit on, how's your baby? What can I do to help you? I take a real simple newborn kit, and in it we have a little bib that some of our people embroidered that says, Jesus loves me. We have some of the cradle roll things that we put in. I'll go and look at the child, we'll talk, we'll hold them, and the conversation will then lead us to, I'm also concerned about the spirit. You know, have you considered the baptism? Have you made any plans for that? Can I answer any questions? I see you have some other children here. Have they been baptized? So we're always focusing on getting to the word of the sacrament, even though the word of the sacrament is not what we are doing. We're doing the parish nursing. We're remembering the real purpose. And we certainly want to involve them in the life of the congregation. People feel really isolated, particularly those people with no family and friends in the area. So how can we involve you in the life of the congregation? Because we also know with friendship and relationship builds wellness. Spiritual assessment. Under nursing diagnoses, there are 4 main ones. The first one is spiritual distress. And spiritual distress is distress of the human spirit. As simple as that. The universal spiritual needs that people have, regardless of their religious background, are a sense of hope. As Christians, we know where our hope is from. Our hope is from our faith in Jesus Christ. But we have that need for hope, whatever your background. So as I visit with someone who may not be a Christian, I can still identify that they're looking for a sense of hope. And we can take that and move it. Sense of meaning and purpose. Why am I here anyway? the person who has no sense of meaning and purpose is probably going to have a problem with depression. Why am I here? And sense of love and belongingness. Another issue is withdrawal. Perhaps the person had been very actively involved in the church, had a good faith life, and something happened. And sometimes that something happened was as simple as somebody did something that annoyed them, or didn't say something when they should have. Many times it's very simple human relationship issues. It may also be that a tragic illness or tragedy happened in their family and they have the big why question. Because they have that, they back off. If we can enter into that and go to them when they aren't coming to us and build that relationship back, we can also get them back. Unresolved guilt. We're all guilty. Not a one of us are not. But we know that our guilt is forgiven through Jesus Christ. But there are people who believe that whatever they did was so bad, God can't possibly forgive them that. And so they wrestle with it. And many times the person is not comfortable sharing that with the pastor. And ultimately we want to get them to the pastor. But right now, many times the nurse is the one who's more approachable. Nurses have seen everything. And so the person feels comfortable because we take a pledge of professional confidentiality. We look at what nurses take care of in a hospital or community setting. Nothing is going to surprise us. And so they can bounce it off of us. And they will share with us. And if we don't reject them and we accept them, then maybe the pastor will too. Many times they will still want you to meet with the pastor because they're still a little hesitant to go alone, but they will go with you. Or sometimes they will, in fact, go alone, but they will try you first. So we deal with a lot of unresolved guilt, and we're going to be comfortable in sharing with them that forgiveness is ours through Jesus Christ. Unresolved grief, same thing. Grief is a normal reaction to a loss, and the more significant the loss, the more significant the grief. But there is a grieving process, and we would hope that we would work our way through it. But some people get stuck in that. And when they get stuck, then many times I have met with somebody and the grief seems so overwhelming. I think someone just died, and when you're talking to them, the death was years and years and years ago. They've just not gotten beyond this. And so we can work with that. Lifestyles of the congregation. What are the eating patterns? Now, as nurses, we know nutrition and what we eat is very important to overall health. But we also know that typically in the United States, our eating patterns aren't as good as they should be. So when we're looking at the coffee hour on Sunday morning, I'll have to say this is one of my big challenges. I will try really hard to encourage people to put out healthy food, and we'll have healthy food and donuts. Usually, guess which one is left? The healthy food, not the donuts. And so people gravitate towards, but at least you've introduced that there's another choice. You know, do what you can to include. When you have a potluck, or maybe you call it a shared blessing, because that's more accurate, isn't it? Nothing is left up to luck. It's all a blessing from God. So if we have a shared blessing meal, what do people bring? Do they bring lettuce leaves and carrot sticks, or do they bring casseroles, bakery, breads, things that are really good, but maybe not the healthiest for us? So we need to look at what are the eating patterns within our congregation. What do they eat? And what goes along with that? Included in that can be a lot of things that we can go with. Exercise. Exercise is another thing that's really important for overall health and wellness. Some churches actually have exercise programs. They may have a walk and talk where you walk for exercise and then later you stop and you talk and you pray and you share concerns. Very simple, it doesn't cost a thing. You do a walk and talk program. You walk, you talk and share whatever your problems are, and at the end you pray for common needs. Other exercise programs, some places, it's actually combining eating and exercise. There are some churches with a parish nurse that are beginning community gardens. And so the community garden has the exercise of hoeing, weeding, planting healthy food, and sharing it with their neighbors. So it's also an outreach. So if you've got an area of land and you've got some people who are good at gardening, it becomes a really wonderful program. And it also can be an intergenerational program, as the adults probably manage it, but if the children get involved in how they can help. Stress management. Stress is common for all of us. And stress is not a positive or a negative. Usually we think of stress as being a negative. But in truth, if we look at stress, there's eustress, which is positive, and distress, which is negative. Our body doesn't know the difference. They don't know if I'm excited because I'm about ready to go on a wonderful trip, or if I'm really upset because I just got fired. The adrenaline and the endorphins act in the same way. And so stress is neither positive or negative. But it has the same effect on our body if we don't do stress management. And of course, looking at the spiritual support. Do we have spiritual support not only on Sunday morning during worship service, but throughout the week? Is that a part of the total life of the congregation? Acute and chronic health care needs within the congregation can include health education, encouraging compliance, maybe a lending library or lending closets. People may need temporarily a walker, a shower chair, a wheelchair. Some congregations that have space and resources may have a place where these things are provided. You don't need to go out and buy it. You don't need to rent it. If you don't have the insurance, you don't have to pay for it. So you can get what you need short term. Along with the lending closet was the lending library, and this would be videos, generally health education topics. It might be books, could be resources. Visiting the person who has acute and chronic health care may not be getting out as often as they used to. And yet then we end up with the isolation and the withdrawal. So if the parish nurse will go and make a visit, it's that ministry of presence. You may or may not have done anything. You were just there. And that made a whole lot of difference. And certainly advocacy. Navigating the healthcare system is not easy for those of us who are healthcare professionals. Think how much less easy it is for the person who is a layperson. You know, where do I start? Who do I call? How do I do this? We can be their advocate, and we can either provide the information or, with their permission, try to make those calls on their behalf. Looking at the emotional health of the congregation as a whole, is there a spirit of friendship? When you come into the church building, whether it be for worship or for a meeting, do the people seem like they like each other? Is there general friendship? Or are they often little cliques not speaking to each other, and the conversation is about each other? Okay. So are we connected or are we not? Do people feel valued? That goes back to that spiritual one of meaning and purpose. If what I have to offer is not healthy and not valued, I'm going to have low self-esteem, I'm going to be depressed, I'm going to withdraw. Do we help one another? Is there a need for support groups? And similarly, we could say supportive groups. Interesting comment on the support groups. We kind of go through support group cycle as much like a trip through architecture. if we think about history, houses were big and they had front porches. People sat on their front porch, and in the evening, the neighbors visited with each other. Then, newer houses didn't have a front porch. If anything, they had a backyard deck. So who was in the backyard deck? Only the family or the individual that was invited in. And this is when families also became more mobile, so there was nobody else just in the area. During that time, support groups became very, very important because the front porch that was a support group doesn't exist anymore. People are isolating themselves in back. And so support groups, whatever you had, the first thing that people think of is Alcoholics Anonymous, but there's a directory of hundreds of anonymouses. So whatever your problem is, there's probably one someplace. In time, people got tired of support groups because it tended to imply that I was too weak and I needed support. So I don't want to go to a support group because I'm stronger, I can do that. So the new term tends to be supportive groups. And that's taking the groups that already exist, choir, the women's group, New Mothers Club, Sunday morning Bible class, whatever there is. And even though the group is not intended as a support group, we take enough time to actually get to know each other, pray for each other, ask, how can I help you? And so this group that is very neutral as far as health is concerned is designed and empowered to be that support that the support group was. And that has worked really well. Community outreach is reaching out to others so that we can share not only the resources of our congregation, but also the concern that we have as disciples of God to go out and care for other people. It may be that we're reaching out to nursing homes, senior living sites, maybe a homeless shelter, food pantries, whatever it is. Every community has something. And in those somethings, we can volunteer to be there. And maybe I'm in the pantry and I might be sharing healthy food, but sometimes the parish nurse once a month will take blood pressures too. And then they'll also have some brochures from their church on different groups that you have going on there. So it's a gentle outreach, but it's an outreach just the same. Collaborating with nursing schools. Many times if you have a nursing school in the area, whoever it is that teaches the community health part is always looking for clinical sites for their nurses. And many of them would be happy to be able to plug in and send their students to you. And it's a wonderful opportunity. I had the opportunity to do that myself when I was also teaching. I rotated my own students, because I taught community health. I rotated my own students through our church when I was on duty as the parish nurse. Now I have to say that was maybe a unique situation, but it was wonderful. I taught in a secular school and all my students came to church with me twice. It was part of their assignment. But we also have opportunities that if you have a school, you might just call them and tell whoever's teaching community health, are you looking for a community site? Because I'm the parish nurse at St. Luke's or St. Matthew's, and if you have students that would like to come over, I would be really happy to introduce them. And in some cases, they may want the student to just come once and get a general overview. And in some cases, they may say, well, we want to do a health fair. Could we do it at your church? Yeah, sure. Because it's good for the students. The students have a captive audience that's going to come to their fair. And it's good for the church. And the students get exposed, so y'all win. So any way that you can collaborate with a nursing school works out well. And it's probably going to be easiest through the community health class, although in some cases, if you have a school, pediatrics might work because they could come and do some things with the kids in the school. Liaison with community resources. Do you network with the homeless shelter? Do you network with the domestic abuse shelter? there may be things that you can provide for them, and together then you're providing a gentle outreach to the community and also an introduction to the services of your church. Assessing the church property. Is it handicapped accessible? Is there adequate lighting? Assistance for the hearing impaired. Again, we're assessing a building. Maybe that's not something that nurses would typically do. We typically assess the person. Is there a nursery? And if so, is it child safe? Is there a restroom? I would hope so. Is there soap and water? And we could go on. You know, are there first aid kits scattered around? Is there an AED? Is there, you know, the list is endless. Someplace there should be office space for the services of the parish nurse. And we have a whole section on that. So let me just take a couple moments to tell you, the office space does not need to be a big fancy office. It just needs to be a place. The place, because it identifies first and foremost that we have a parish nurse, because this is the parish nurse's place. It probably has a sign on the door so that when people walk by it, they continue to know. So it identifies that this is a part of our church's ministry. It identifies that you're there. And it also gives you a place to keep your resources and your charts and your things that you need without needing to keep them in the trunk of your car and just keep bringing the box back and forth. You know, and I know some nurses who do that. They can't find a place, so they have a box. And when they come into church, so does the box, and when they leave, so does the box. But that's really unhandy, and I'll share more about that later. Parish nurses learn to adapt as needed to their environment, as well as learning how to adapt the environment as needed. Can you think of any examples from the churches that you're connected with where there may be something in the environment that either is going very well and it addresses one of these physical needs that one of your congregants might have, or conversely, you need it, but nobody has ever yet thought to do it? You know, you have somebody in a wheelchair and everything is on the third floor and there's no elevator. That's a need, you know.
So we recently developed what we call a Merry Widows group. And
Wonderful.
so it has really grown where there's been an outreach to other women in the community,
Good.
not just members of our church.
Absolutely.
And they meet on a monthly basis, and then two women will decide where they're going to eat, whether it be at church or at a restaurant. And it has been a very supportive group, and it has mushroomed.
Yeah, and that's an example of recognizing an emotional need, the grief, the social need, the isolation, and maybe the spiritual need of, okay, where do I belong now? Because I was part of a couple and now I'm not. So you may actually have at least 3 needs altogether. And the fact that you have included others, it becomes a catalyst for networking, whether they're members of another church and you're just reaching out and caring for them, or maybe they're totally unchurched, and this may be the thing that attracts them to your church, that they're involved with your widows group. Okay, good group. Anything else?
Our church has pretty much kept up with the physical need, handicap, you know, a place for wheelchair and the elevator facilities, because we are up on sort of a hill and ramps, but they're also expanding now, and there's going to be more room and accessibility so that everybody's, you know, can get in.
Yeah, that accessibility becomes just really important, because we can invite you to our church and we can say with our mouth that you're welcome, but if there's no way you can get in the building.
Yeah, if you have to go steps, then you got to bend.
Yeah, and if you do get in the building, some places have a ramp to the front door and you can get to the building, but you can't get beyond the narthex because everything else is up or down someplace. So, and you know, we're not really great at that, you know, where I'm at. We do have capabilities, but we don't have an elevator, you know, and I wish we did someday. Okay, anything else?
I was just going to mention a practical was our procedures for emergencies.
Okay.
I just noticed our manuals were outdated or weren't updated, especially since we've been adding on. So making sure rooms have evacuation plans and working with the elders,
Absolutely.
making sure that if something happened during services, what would happen? How could we respond to any type of emergency?
Absolutely, and we certainly hope none happens, but they do, don't they? And the time to develop one is before.